Coma and encephalopathy. Coma is a state of unarousable unresponsiveness, characterized by unconsciousness with limited to no response to external stimuli. Lesser degrees of impaired arousal are termed obtundation or stupor. Coma results from dysfunction of both cerebral hemispheres or the brainstem, pons, or higher, due to structural or toxic metabolic insults. Common causes include encephalopathy, hypoxic or ischemic, diffuse axonal injury, brainstem herniation, electrolyte disturbances such as hypoglycemia, toxins, and central pontine myelinolysis. History and physical examination. A complete medical history should be obtained from witnesses, including current medications, particularly sedatives. A thorough medical and neurologic examination is essential, including assessment of mental status, spontaneous motor activity, muscle tone, breathing patterns, fundoscopy for papilledema, pupillary size and light response, eye movements, corneal reflex, gag reflex, and motor or autonomic responses to noxious stimuli applied to the limbs, trunk, and face, such as retromandibular pressure or nasal tickle. Diagnosis. Diagnosis is typically made by combining history, physical examination, and laboratory tests or neuroimaging. The best initial step includes checking glucose, electrolytes, calcium, renal panel, liver function tests, arterial blood gases, toxicology screen, and blood and CSF cultures. Next, assess vital signs, ventilatory pattern, and perform a detailed neurologic examination to identify treatable conditions such as infection, metabolic disorders, seizures, intoxications, overdoses, or surgical lesions. CT of the head is the test of choice, while MRI is superior for detecting encephalitis, early strokes, diffuse axonal injury, and multiple small hemorrhages. Lumbar puncture and electroencephalography should be included when neuroimaging and metabolic studies do not reveal the cause. MRI is particularly useful to exclude structural changes and ischemia, especially in the brainstem. It is important to rule out catatonia, conversion unresponsiveness, locked-in syndrome, or persistent vegetative state, which can mimic true coma. Locked-in syndrome, persistent vegetative state, coma, and brain death can be differentiated based on alertness, causes, voluntary motor ability, and respiratory drive. In locked-in syndrome, the patient is wakeful and aware with retained cognitive abilities. In persistent vegetative state, PVS, the patient is awake but not aware. Eyes may be open or closed, and sleep-wake cycles are present. In coma, the patient is unconscious with eyes closed and has no sleep-wake cycles. In brain death, the patient is unconscious with no sleep-wake cycles. The most common causes of locked-in syndrome include central pontine myelinolysis after rapid sodium correction, brainstem stroke, and advanced amyotrophic lateral sclerosis, ALS. For persistent vegetative state, common causes are diffuse cortical injury or hypoxic ischemic injury. Coma is commonly caused by diffuse hypoxic encephalopathy, widespread infection, electrolyte disturbances, or toxins, and brain death share similar etiologies. Regarding voluntary motor ability, patients with locked-in syndrome can move their eyes and eyelids, whereas those in persistent vegetative state, coma, or brain death have no voluntary motor ability. Finally, respiratory drive is present in locked-in syndrome, persistent vegetative state, and coma, but absent in brain death. Key fact: artificial life support should be discontinued only after declaration of legal brain death by 2 physicians. Treatment. Initial management involves stabilization of the patient with attention to airway, breathing, and circulation. Reversible causes should be addressed promptly using the DON'T protocol: dextrose, oxygen, naloxone, and thiamine. Identify and treat the underlying cause and any associated complications while taking measures to prevent further neurologic damage. Clinical case. A 68-year-old man presents to the emergency department with numbness and droop on the right side of the face, inability to speak, and numbness and weakness in the right arm that began 2 hours ago. Where is this lesion, and what is the next best step in management? Occlusion of the left middle cerebral artery, MCA, is suspected as aphasia and contralateral sensory loss and weakness are part of the description. CT of brain without contrast should be done to rule out hemorrhage and assess whether TPA should be initiated. A 59-year-old man with prior medical history of polycystic kidney disease was admitted for treatment of SAH. 4 days after admission, he developed weakness in his right arm. What could have prevented this? This patient's focal weakness is probably caused by ischemia secondary to vasospasm, so nimodipine administration could prevent this adverse event. A 59-year-old man with prior medical history of polycystic kidney disease is admitted for treatment of SAH. 4 hours after admission, he develops weakness in his left arm. What is the cause of this new finding? New onset of neurologic symptoms within 24 hours following an SAH is most likely caused by re-bleeding of the aneurysm, as opposed to ischemia days after, which is caused by vasospasm.